Welcome to Westchester Jewish Community Services. As a leading agency in providing a comprehensive spectrum of human services, we have been helping people since 1943. We serve all people in Westchester County, regardless of age, income, or ethnicity. We provide a wide variety of essential and dynamic services that make a difference in people's lives. Children, teens, adults, and senior citizens are served by our network of programs located throughout the county. When people come to us for assistance, they become part of the WJCS family. Our highly trained and skilled staff focus on you and your family and are committed to becoming your partner in finding solutions. For more than half a century, we have been connecting people to services that help them overcome mental, physical, or emotional challenges. WJCS is here in your community when you need us.
Welcome to the Ways We Care of Westchester Jewish Community Services. I'm Dale Wang, Director of Community Relations. WJCS is funded by UJA Federation, United Way, government grants, private individuals, foundations, and corporations. The challenges of maintaining healthy minds and bodies are faced by all of us. For people with special needs, these challenges may be complicated by additional mental and physical conditions which affect their well-being. As a result of a recent incident of an unusual virus spreading among residents in a group facility, we wanted to explore with professionals the issue of medical and behavioral health care among people who are developmentally disabled and in residential care. Recognizing that no institution is immune to potential infections or viruses, we will look tonight at measures that organizations such as WJCS take to best prevent potential outbreaks and to ensure proper medical and mental health supports for those in our care. We hope to give viewers an insight into the tremendous efforts made to maintain the health and well-being of people who live with us. You will no doubt be impressed by the high degree of attention and compassion provided by health and mental health staff and professionals toward individuals with developmental disabilities. To introduce us to WJCS's Community Residential Care Division and to the efforts being made on behalf of people in our care, I'd like to introduce you to our guests tonight, Steve Yellen, who is a CSW and Assistant Executive Director for Community Residential Care at WJCS. Welcome, Steve. Ellen Laminoff, who is an RN and Coordinator of Nursing Services for the Community Residential Care Division. Welcome, Ellen. And Dr. John Hammer, who is an internist in the White Plains community and who works with our residents. So thank you for joining us, Dr. Hammer. Steve, let's give people, because they may not be familiar with our residential care system, an idea of the scope of services that we have for people who are mentally retarded and developmentally disabled.
Sure. We have presently 12 homes that will soon serve 89 individuals. These are all adults, and the individuals we try to group them, so to speak, homogeneously, so that they are living with people of similar kinds. And the homes range from 6 people to 12 people, and they're scattered really in regular neighborhoods throughout Westchester County. We serve people who are younger, in their early 20s, and we serve people who are much older, well into their 70s, 80s, and even 90s. We serve people with a significant amount of cognitive impairment to people who have much, much higher abilities and skills and are much more capable. We serve people with some high medical needs at times, and we serve people whose health are really much more intact. So it's really a very diverse population within the universe residentially at WJCS.
Who are the people who are eligible to be in our care? People can't just call and get served by our system.
Well, people who are eligible are those people who meet the eligibility criteria set by the state, are listed on the Department of Community Mental Health registry and are signed up on the New York Cares waiting list. And these are people who are usually adults, although sometimes people a little bit younger can come into the residential care system. And these are people all with some kind of developmental disability that's documented, that's been tested and proven. And after that, there also just needs to be a desire that there's either a need or a want to live in some kind of apartment or group living facility.
Mm-hmm. So basically, if someone is an adult and their families or they are unable to be cared for, or if they're just ready to move on and live independently, they can be accommodated in this type of setting.
Yes, they can. It all really depends on space and time frames and family situation and individual's desire. But the package comes together, and the purpose now, the point now, is to try to make sure that those people who want to live in some kind of situation, whether it's an apartment or a group home, small or large, at some point will be able to access those services.
Mm-hmm. You had mentioned that there's been a change in the demographics over the past decades. I mean, we've been in the business of residential care for almost 25 years now.
Yes.
And we started out with people who were probably middle-aged at that point. Give us a picture of what it looks like today.
Well, let me just roll the tape back a little bit, in that we have served a number of people. About a third of our people are 60+ years old, and about 20% of our people are over the age of 70. But as the years have now gone on, as they've aged, some of those people are no longer with us. So the people who are really now looking for service are generally those people who are younger. So we see that at one point we were more skewed to an older group of people. Now the people coming into our homes are much younger. In fact, the newest group that will soon move into one of our homes are all in their early 20s. Mm-hmm. So that's really a major change that's now happening. Before, since there were so few opportunities, the people almost had to be in crisis before they could get into some kind of residential placement. And they generally were older, their parents were older. But now, since most of those people have been accommodated, the people who really want it and are desirous of it can come in, and they come in at a younger age.
Uh-huh. Okay. As I mentioned, the impetus for this program was really to allay people's concerns about what happens when people are living in a group situation and how infections and disease can be prevented from being spread to vulnerable populations. What I really found to be reassuring in speaking to all three of you was the emphasis on prevention and on a real commitment to healthy habits. Let's talk a little bit about how this is implemented in the group home setting and how you will work to ensure that that philosophy really comes through in the actions. Ellen, let's
Well, I have a wonderful nursing staff. 5 RNs cover our 12 homes, and depending on whether a nurse works full-time or part-time, she may be responsible for 1 to 3 homes. And when I say responsible, this means that she will be overseeing and vigilantly checking all of our consumers' health care needs as in terms of prevention, as well as if there is illness. Mm-hmm. Every consumer has their own primary care physician. Dr. Hammer is one of them who takes care of many of our consumers. And the nurses enjoy a very close working relationship with all the primary care physicians. The staff and the nurses, everybody works together. The nurses are, if they're not physically in the home, they're always available by pager. They're literally on 24 hours a day, 7 days a week. They're on call during the week for their homes. On weekends, one of the nurses is always on call for the entire weekend. And staff is encouraged to call us if they have the slightest idea that something may be wrong. And so we're notified very quickly of any fevers, somebody not acting right, someone not looking right, any symptoms at all. The nurse will be notified. The nurse triages the situation, makes an assessment. Doctor is notified. If necessary, the consumer is taken to the emergency room. No time is wasted. And I feel this vigilant, constant monitoring of their health is so important, and what keeps us so far at in a very good place. Mm-hmm. We keep statistics of all of our infections, and It's reported out quarterly to our agency, and our rate has been very low, I'm very happy to say, and I believe it is this vigilant monitoring at all times between the staff and the nurses and the physicians.
Mm-hmm. What are there particular issues that would affect a population that is developmentally disabled in a way that is out of the ordinary for people who don't have those cognitive disabilities?
Well, I think the main thing for us as nurses and people taking care of this population is so often they cannot articulate or express what is bothering them. So unlike you or I, we say, oh, I've had a headache for 3 days. I guess I should go to the doctor. Our consumers often can't express that in any way. And the only way we know that anything is wrong is by a change in their behavior, a change in how they look, anything like that. Maybe they're not eating as much as they usually are. Maybe they're pacing. There are all different things, all different behaviors that we'll see that are unusual that will cue us that something's wrong. Because so many of them really cannot say, I have a pain in my stomach, or my leg hurts, or anything. And so we're very, very alert to that. And so that's extremely important, because if you don't pick up on those things, something could go much longer than it should. And then instead of treating something simple, you're treating something complicated.
Dr. Hammer, when you're called in to, do you do regular medical examinations with the consumers, and so you see these people on a regular basis?
Yes, generally all the consumers have an annual physical, and they get their immunizations at that time, and any health care issues are concerned or concerns are taken care of. It really is a multidisciplinary approach. What Ellen said was very accurate. The most important people in this healthcare chain are not here this evening. It's the staff who are with these consumers each day and notice these subtle nuances in their behavior that might trigger a call to me or a doctor's visit, at which time we can sometimes make a diagnosis. So it's they who deserve the most credit here. The most important thing, I think, in preventing any of these outbreaks of viral or other illnesses, as we had in Yonkers not long ago, is the prompt recognition of several individuals getting sick simultaneously. I think that's the clue. Everyone could have a cold or come down with upper respiratory symptoms, but if you see it's 3 or 4 around the same time, you should be alerted to the possibility of something going on.
Now, when you deal with people who have developmental disabilities, what kind of special skills do you feel that you need in order to communicate with them?
Well, I generally treat them as I would any other individual. I think it's important to establish a rapport with them, and the easiest way to do that is with a smile, with a greeting. I speak to them as I would speak to any patient, and eye contact is important, a gentle touch is important, and often you find we don't know how much they really can understand, but I think anyone appreciates a smile and a gentle touch. You examine them as you would any individual, and they get otherwise the same care that anyone would, in fact more. We have dental covered, psychiatry is covered, podiatry. Almost all the ancillary specialties are included in, again, this multidisciplinary approach to care.
Yeah, I think that was one of the things that was so apparent, was that sometimes these residents get more care than someone who is outside of that sort of system.
Well, there's always someone looking after them, whether it be the nurse or, as Dr. Hammer said, the direct care staff. There's always someone there, and we're very fortunate that our staff really knows the people who live in their homes, and they can pick up those subtle nuances and changes. And when that happens, whether it's a cough, a cold, a sneeze, a small change in behavior, you know, out comes a thermometer, a blood pressure cuff, somebody's taking a pulse, and they're really starting to do early on an assessment so that we can intervene as quickly as we can, in part because sometimes some of our people can't clearly articulate what's really bothering them.
Ellen, you had talked at length about the infection control procedures that you have in place in the homes on a regular basis.
Yes.
Could you just talk a little bit about that?
Absolutely. When staff, anyone who's going to work in the homes in any capacity, but particularly the direct care staff, before they really set foot into the home, they take part in an orientation program. And part of the part that I do, that I teach, has to do with infection control, management of emergencies, first aid, seizure management, things of that nature. The bulk of it is spent with infection control matters. And it's several hours of information that we discuss during the orientation period. What is stressed is universal precautions, which simply means that you don't need to know anyone who has any disease. You don't need to know who's HIV positive or who has hepatitis. All you need to know is that if there's blood or body fluid anywhere where you're working, you're going to use your gloves. You're going to have certain ways of cleaning things up, certain ways of handling trash, certain ways of throwing certain things out that's considered medical waste. There are procedures for all those things which are taught. And of all things, the simplest thing is hand washing, hand hygiene, it's now called. And I cannot stress enough, and we talk to the staff about this, I would have to say probably every single day, that hand washing for the staff as well as for the consumers is the most important thing anyone can do in infection control. And anyone who works with infection control knows that. The interesting thing now is that the alcohol-based gels, such as Purell, that sort of thing, there have been studies, and the CDC is now recommending that they're saying it is just as effective, if not more so, than regular hand washing with soap and water. But irregardless of how you do it, you got to do it. And we make it convenient, we make it easy, we stress it, and we do that in orientation. There's then a series of mandatory programs that staff have to take every year, one of them being infection control, so that everything that's taught in orientation is reinforced during that mandatory training, which is once a year, as well as ongoingly in every staff meeting and every staff training by the nurses, so that we are always discussing this. We also have a very vigilant tuberculosis control program. We have a vigilant hepatitis control program, so that these things are monitored, and if there's any exposure or question of any exposure, we're on top of it immediately, very, very quickly, discussing it with the physician and taking care of what has to be taken care of. And keeping very, very strict statistics.
Right. You said that you keep in touch with the CDC on a regular basis.
Yes, the CDC has an amazing website, and it's extremely helpful. I think I'm on it probably every day. And I mean, you can get information in an instant that you need if you have questions, concerns. I mean, it's just unbelievable. As well as our own state and local Department of Health. They're extremely helpful, even if it's not something that has to be reported. You're not under a law to report it, but if you need information, they have written information on everything, and they share it. They advise us. There are nurse epidemiologists that work locally that I can pick up the phone and call and be speaking with in less than a minute. I have there are many resources, and we use all of them, and the doctors, and you know, there's plenty of information. There's no reason not to know.
Right. Dr. Hammer, as a result of that incident in Yonkers, and I'm sure it wasn't the first and it won't be the last, is there concern in the medical community generally about institutional care and spread of disease and infection? I mean, living in a group home is like living in a big family, I suppose.
Sure. There's always concern. There always will be concern because there's no way we can really prevent these things from happening. We can keep surveillance and take the appropriate steps once we have an index of suspicion. The incident at Yonkers, just to touch briefly, that involved a fairly common virus, which is commonly found in the community. It causes upper respiratory symptoms, which are often indistinguishable from the flu. And when it, however, presents itself in a population group or cohort such as our clients, then it can have more devastating effects. But again, it can enter the home through a cold or any other way.
Right. So it really is not unusual. This could happen in any family where there are people living together. And our consumers are also going to day programs where they interact just as other people would.
They're very much out in the community, and then there's a variety of people in addition to the staff, but there's families and friends that come and visit the house. So there's a lot of opportunity for things to arise, but it's being on top of it that's really important, and knowing what to do when it happens.
Right. So we are very vigilant about the training of our staff and the safety control and infection control. What types of government regulations are imposed upon organizations like ours that operate group facilities so that people out there know that we have to comply with various regulations?
All of our group homes, and most every group home that exists in New York, has an operating certificate issued to them by the New York State Office of Mental Retardation and Developmental Disabilities. And with that operating certificate comes a whole host of regulations. Some homes that currently exist throughout the state also have a layer of federal regulations on top of that. So whether it has to do with treatment or care or medical care or behavioral care, etc., we all have to comply with basically the same set of regulations depending on the type of home that one lives in. In the very least, annually, the state will come in to check on how we're doing. And they visit. Usually it's unannounced. They'll knock on the door at 6 in the morning and say, "We're here." And then they come in and they observe, they look at records, they talk to consumers, they'll talk to families, they'll visit day programs. They really want to get more than a snapshot. They really want to get a slice of what's happening and see how we're doing. Measure us against those standards that they have set. Occasionally the feds even come in and take a look-see after the state's done their look. For us, we have a layer on top of that being JCAHO accredited, Joint Commission on the Accreditation of Healthcare Organizations. And once every 3 years, those individuals come in and look at our group homes. And many of those regulations are very consistent with the state and the federal regulations. And then there's some things that are particular to JCAHO that we as an organization comply with. So that there really is very strict standards in terms of how we operate, how all agencies operate, and there's a set of standards in terms of expectations that we need to meet at all times, every day.
So people can feel pretty comfortable that if we are taking their loved one and providing care for them, that we are complying with all of these regulations and doing more than is expected.
Absolutely.
Right.
And in addition to the survey process, there's always the supervision process and the occasional agency internal survey process that most every organization goes through. So it's not just a moment in time when the state comes in. It's an ongoing process. And as Ellen mentioned, her quality improvement piece, well, as an organization, many organizations, they have quality improvement projects that exist. And that keeps everybody on their toes to make sure that we do the right things.
So if there is something, we take a look at it, figure out how to fix it,
Exactly.
and try harder the next time.
Correct.
We have about 4 minutes left, and I would like to get a quick snapshot because I think it was so interesting to hear how you dealt with the situation of a quite ill person in one of our homes. And maybe, Ellen, you can give a very brief idea of how this all worked together with the medical people.
Sure. It happens that the woman that I'm going to tell you about is a patient of Dr. Hammer's as well, so he knows this situation extremely well also. I want to say that when our consumers have to be hospitalized, it's a special situation, and each consumer, we decide how much staff they need, how often they need staff with them when they are hospitalized. Many of our consumers have staff with them 24 hours a day, so they are never left alone in the hospital. And the one that I'm going to tell you about is one of those. This is a woman who lives in one of our residences. She's severely retarded. She's autistic. She's 57 years old and has resided with WJCS for 21 years. She's also autistic and has type 2 diabetes. Everything was going along fine when in early 2002 she started to develop anemia, and she was seen by Dr. Hammer. She was referred to a hematologist. She was treated with B12 and things were going along okay. And then her blood sugars started to be higher than usual. She had been fairly stable on an oral medication to keep her blood sugar stable. And so this combination of the anemia and the blood sugars rising alerted her nurse, whose name is Liz. Liz got quite concerned, spoke with Dr. Hammer, and between the two of them, they were working on this for quite a while. She was seen by the endocrinologist, the hematologist again, and so forth. Finally, one weekend, her blood sugar really reached a critical level, and she had to be taken to the emergency room at St. Agnes, which is now Westchester Medical Center, White Plains Pavilion. And she was admitted there and had a bunch of diagnostic procedures, and it turns out that a large tumor was found on her kidney.
Oh.
And she was quickly transferred to Westchester Medical Center, where it was removed. Her entire kidney and the tumor was taken out. I don't know if you can imagine all of the things that had to go on, all the communication, all the specialists. There were 4 or 5 doctors involved. There was staff with her. There was the woman herself who was not verbal. There was the transfer to another hospital. There were consents that had to be gotten. It was quite complex. With all that, she managed to be discharged 1 week after she had this surgery. Liz was at the hospital every single day, making sure that she was comfortable, that her needs were met, that her pain was managed, that she was clean and cared for, and thank God there were no complications. Right. She came home in a week.
Right.
Now, in that week, we then had to teach the staff, because the woman had to be put on insulin to manage her blood sugar temporarily. Well, our entire staff had to be trained in diabetes and how to give insulin and all these things, which is kind of complicated. And in that 1 week, we trained the entire staff in the house to take care of her when she came home.
I think one of the other things that was so interesting, and we only have a half a minute left, is that it was also so important to the staff to get her back into a comfortable situation and to accommodate her needs in that way. And I just think that you did an amazing job. And it really shows how working together, you can be on top of something, you can pick something up, and that we're able to translate the needs of people who are not able to speak for themselves or necessarily to prevent some of these things themselves.
Interestingly enough, post-operatively, her diabetes actually improved, and she no longer required the insulin. So much of these symptoms, the anemia, was due to a paraneoplastic syndrome.
Right. Well, I thank you all. I told you that the half hour would go very quickly. And I thank you for helping allay the concerns of people about what it's like to be in residential care, and to give insight into some of the considerations that people have with developmental disabilities. So thank you very much for your time.
You're welcome.
Stay tuned for the second half. We'll be talking about some of the mental health issues that are faced by people with developmental disabilities. Welcome back to the Ways We Care of Westchester Jewish Community Services. I'm Dale Wang, Director of Community Relations. WJCS is funded by UJA Federation, United Way, government grants, private individuals, foundations, and corporations. Maintaining healthy minds and bodies is a challenge for everyone. People with developmental disabilities often face the additional challenge of trying to communicate their needs so that they can be understood and properly cared for. During our first segment, we examined how medical issues of consumers with special needs living in WJCS community residences addressed their needs through the outstanding nursing, medical, and direct care staff. Our guests in this half will focus on helping to treat the behavioral health aspects of people with developmental disabilities so that individuals may function to their greatest potential and establish relationships that give them satisfaction and support. To give us a little bit of insight into how we work with some of our consumers with developmental disabilities, we've invited some of our specialists on staff. Leslie Catan, who is Director of Outpatient Programs for People with Disabilities.
Hi.
Welcome, Leslie. Jay Selinger, who is a vocational rehabilitation counselor with our mental retardation, mental illness track at the day treatment program. Welcome, Jay. And Dr. Margarita Munoz-Dummett, who is a psychiatrist with WJCS. Thank you for joining us. And I'm going to open this up to everybody to discuss. Leslie, maybe you can begin and give us a little bit of insight into to what extent the behavioral and mental health issues of people with developmental disabilities are affected by their cognitive deficits.
Well, the literature suggests that people with developmental disabilities are just as prone to, if not more so, to various emotional or psychiatric disabilities. Some of the literature suggests as high as 30 to 40% of those people with developmental disabilities over the course of a lifetime will also develop a psychiatric disability or psychiatric issue. So that of those people living in our group homes and people with developmental disabilities in the community, there's a fairly significant number of people who also are struggling with issues emotionally. So we see a full range. Unfortunately, the developmental disability doesn't prevent the psychiatric issues, and they are susceptible to similar psychiatric issues almost across the board. If you look at the DSM-4, they unfortunately are also affected by all of the psychiatric disabilities. So we see quite a bit of that in the clinic.
Can you give us a range, the idea of what kinds of programs we have? You're in charge of our outpatient services. What is the range of programming that you might be offering to families and people with special needs?
Our program is part of the General Family Mental Health Clinic. We have a staff of 4 clinical social workers and a psychiatrist specifically working with this population, and like anyone else who might walk through the doors, our consumers are seen for individual, family, or group counseling, depending on their level of ability to use treatment. Some of them may be participating in more insight-oriented kinds of treatment. We do a lot of cognitive behavioral intervention and behavioral interventions in addition to the psychiatric services that our psychiatrists provide. But we have specialized programs for both children and adults. In addition to the psychotherapy, we have a variety of groups going on. We have a group specifically for teens, an adult social club, an adult psychotherapy group. So it's quite a range within a typical clinic setting.
And you're also dealing with young children. I understand that we're doing a little bit more work with some of the younger population.
Absolutely. Over the last 2 years, and this past program year specifically, we have 50% of our referrals are children under the age of 18. So increasingly we are seeing younger children, and as a result we're also working more intensely with families. Most of these children are living at home, and you really need to be very much in contact with the families as well. I don't think we're seeing any children who are living in group homes.
Is there a reason why there's been such an increase? I mean, 50% increase sounds tremendous for mental health issues among this population. Is there a reason why you feel that this is it greater identification, or?
I think there are a couple things going on. I think that the schools are getting better at identifying multiple issues, so not just learning issues, but also cognitive and psychiatric issues. I think families are more aware that just because their child has a developmental disability, their behaviors can't always be explained just by the developmental disability. I think people are smarter. I think physicians are smarter as well. I think there's an increase in the number of children being diagnosed in the autistic spectrum range. And I also think that there's a willingness on our part to see children, and so I think people are aware of that in the community, so we're also getting those referrals more frequently.
Okay, let's talk a little bit about what would be specific in terms of how you would assess and look at some of these issues among individuals with developmental delays.
Well, one of the things, I'm both an adult and a child psychiatrist, so one of the things that I look at when I'm doing an evaluation of someone with a developmental disorder or mental retardation, I try to figure out what their mental age is, and that sort of gives me a sense of what behaviors would be appropriate. Because lots of times, if someone has moderate mental retardation, their behaviors would be, they could be 18, but their behaviors would be a lot more like that of a much younger child. So I think one of the things when you're doing an assessment is being aware of what their mental age is, what would be normal behaviors for that mental age, and then looking at behaviors that would be out of their mental age as behaviors that would be concerning. That's one of the first things that I look at in the assessment plan. Also, for a family, for especially the community-based clinics, for a family who's this is their first child with a DD disorder, they may not be aware. They may have other children who are functioning at a much higher level and be comparing their child to that level. So that's actually something important to look at. The other thing is that not all, but a lot of these patients can be very concrete and very limited in their description of behaviors. So you want to take a clear history of the client's behavior, but also you want to rely a lot on parallel resources, and that could be the family, it could be the pediatrician or a neurologist that's involved, the school personnel, or in the case of the residents, the residential staff, because lots of times they may not have an awareness of their behaviors as being problematic. They may not be able to really identify the problem. Like they may say they get into trouble, because of this or that. But a list of those behaviors by the other parallel resources, I think, is crucial in making a diagnostic determination. Also, in the whole evaluation process, using language that is appropriate to their developmental age is also very important in sort of solving this mystery, because it really is almost like solving a mystery when they come into your office and you get a list of symptoms. I remember one woman who had been misdiagnosed, unfortunately, as a schizophrenic. She was a traumatic brain injury patient that came into the office, and she had classic symptoms of what I thought were bipolar disorder, but she really was nonverbal. So, you know, with bipolar disorder, you get extremes of mania and depressive periods. And mania sometimes presents in hypersexuality. So her presentation was she would have periods where she would take her clothes off. She was wheelchair bound, and she would take her clothes off. And then there would be other periods where she would be going into the kitchen for knives. You know, and these periods lasted like 2 weeks at a time. So they, you know, she had been in another facility before and had this diagnosis of schizophrenia, but when you, and had been on antipsychotic medication for that, but when you took a clear history and spoke with the home health aides who had done a beautiful job of taking care of this young woman, and you know, she was placed on the right medication, she really flourished. So that's just an example of you know, the importance of taking a good history and taking your time in developing a diagnosis.
Right. It must be very difficult to have lack the communication skills to be able to express what is bothering you.
Right. I mean, I think as Ellen and Steve had suggested in the earlier part of the show, because the communication skills sometimes are not as good and the descriptions are less thorough, we really do rely on people in our client's environment to help us to understand what's changed. And psychiatric disorders in our clients often become behavioral, and so we really need to see and hear from people in their world and what changes they have seen in terms of behavior to understand and make an accurate diagnosis.
Now, the assessment, of course, is the first part. And how then do you adapt treatment to help people deal with the disorders once they are recognized?
One of the things certainly that we have to do is a psycho-ed piece, depending on the client, either with the client themselves, and hopefully that would include the client, but also for younger children with the families, and help them to understand what they're seeing. Language becomes very important in how you speak to clients. As Margarita had suggested, developmentally, if you're talking to someone who's functioning on an 8-year-old level, you wouldn't speak to them as though they were 18, even though chronologically they might be. Pace is very important, repetition, role-playing are all some of the concrete ways, even things as simple as teaching emotions. I've had a client who I brought a mirror into the office, and we would practice different facial expressions as a way to help her to notice when she might feel happy or sad. And we would start with very simple kinds of labels so that she could then be able to describe to people how she was feeling. So it's a little creative and a little more concrete, and probably slower, and more repetition is required.
How do you assess whether you have made strides? I guess that's hard in the whole mental health field, but especially with people who have the cognitive deficits.
It's a challenge. I think baby steps is a concept that we use a lot for ourselves, and very small steps can be very worth celebrating. I think one of the frustrations, certainly for the clients themselves and also for staff, is that it's hard at times to generalize coping mechanisms from one situation to another, so that while a client may have made progress in managing a particular issue or emotion, in a new situation, it's a whole new situation, and oftentimes we have to teach across situations. So you know, we try and make realistic goals, and sometimes they're very small, but certainly they happen.
Dr. Munoz, is there a difference in the medications that you would use, given the multiple issues that might be going on with some of these clients?
Right. Well, you know, a lot of the DDMR population has what we call comorbidity. That means that they may have multiple medical conditions, for example, Down syndrome. has a very high incidence of cardiac abnormalities as well as hypothyroidism. So that's where a good medical background and working with either the pediatric or the medical team is really a key component. Because also when there's a medical decompensation, their behavior may also decompensate. And we see that more with the moderate and severe mental retardation population, where the first symptom of an illness may be a behavioral decompensation. And I've had cases where a patient has developed cancer and their first symptom is agitation, or an increase in depression. And lots of times it's hard to sort out. For example, with depression, you can get something called neurovegetative symptoms. So there may be a decrease in appetite or trouble sleeping, but that can also happen with a lot of medical illnesses. So it's really closely monitoring their medical condition, working in a team approach with all the members involved. And getting a good history from the parallel resources, the family or the residential staff. And keeping in mind that they may have other medical conditions. As a general rule, I tend to start with a little bit of a lower dose, although I use pretty much all the different categories of medications that are used for regular population. It isn't always the case that they need a smaller dose of medication, but I think they're maybe more susceptible because of brain wiring to certain side effects, especially abnormal movements, and also the cardiac side effects they have a higher rate of. So it's important to monitor them medically and raise the doses very slightly.
And I'm sure that this is an ongoing conversation with families and
Always,
and with care providers.
Sure.
One of the benefits of people being served by a comprehensive agency like WJCS is what we call our continuum of care. So that someone may start at 6 years old and then they may go into our FAD program for teenagers, and then they may be served in our adult clinical programs. But Jay, you have a very unique program in this continuum of care, which really prepares people to go out into the world of work. And it's really a next step. Can you talk about how you relate, who the clientele is, and how you get people into your program?
It's, the people that are referred to our program are from everywhere in the community. We're located in North White Plains, and we receive referrals from basically clinics, from parents, even self-referrals. Many of the individuals have been working at one time in one of the vocational agencies, perhaps the Keon Center or Westchester Association for Retarded Citizens in Mount Kisco and White Plains. And for one reason or another, the individual has lost their job, maybe decompensated to the extent that they're unable to get along with other people or act out or have certain provocative behaviors. And our role is to bring them back into the world of work. And we attempt to do it at we start at a very basic level. I do a preliminary vocational evaluation, evaluating interests, activities of daily living, communication skills, everything that would go into returning to the world of work.
Now, you had mentioned that some of these people come through a program called VESID.
Yes.
Can you just explain how this goes? Because
it's under the Department of Education. VESID was formerly the Office of Vocational Rehabilitation, and its role is to help people with disabilities return into the working world. Usually they're sent for a diagnostic vocational evaluation. I work very closely with both VESID and the individual, almost like a liaison, to make sure that everything goes as smoothly as possible. Some people, it takes maybe a month or so to get involved in the state system. Sometimes it may take a couple of years. We have people who are in various levels of that process. We run work readiness groups at our program to develop their work skills, socialization skills in particular, even communication skills, how to have a friendly conversation with someone.
What is the role of work in this scope of mental health services for people with developmental disabilities?
Well, if you talk to the individuals in our program, you'll find, and in the community, you'll find that work is the #1 goal next to residential placement. Although 1 out of 5 individuals is placed into work. It's something that is quite a challenge for the community, but there are lots of services available to assist an individual get involved in work, and work is a very therapeutic process. Among the general population, I mean, work structures your life. It gives you goal, it gives you satisfaction. You're assisting other people. You're helping yourself. You're developing your independence. Independence is very important.
I think if I could add to that, there's also a sense of normalization that our clients is very important to them, that they be part of the typical, I hate the word normal, but normal society. And so in addition to self-esteem and money and structure, it helps people to feel like they are an active member of our society, and I think that's so crucial to our population.
So the work program involves helping people learn these basic skills, the job readiness skills, but then you also do some actual job tasks. You want to talk a little bit about that?
At our program, we'll do anything from cleaning, working with the cook in our kitchen. We serve a hot meal during the day, so sometimes our consumers will assist the cook in preparing the meal. Sometimes we go over to the WJCS main office and we do some letter stuffing and mailing and folding. And although these seem to be rote tasks, as a form of vocational evaluator, it gives me a chance to see how well someone pays attention to a particular task, how much, what type of dexterity they have, coordination, how well they get along with other people they're working with. We have almost like a team task. It's what we'd call an enclave, which is a group of individuals who are working with a work supervisor and working together on a task. There are various levels of the employment process, from sheltered employment, which might be in a workshop, doing piecework, to enclave work, which is going out into the community but working as a group with a work supervisor, to individual supported employment, which is working at a regular job with the assistance of a job coach, to transitional employment, which is working at a job for a short period of time and getting the experience. There's also volunteer work available in the community, and even competitive employment if the individual can sustain it.
So how do you all interact together to make sure that this enhances an individual's progress? We only have 3 more minutes to kind of sum up here.
I think without question, whether we're all in the same clinic or not, or the same program or not, I think when we share a client, one of the things that I love about referring to the MI track is that it's a very therapeutic and supportive environment. And Jay and I have shared clients, we've transitioned clients, and there's been contact both with with the social workers and also the psychiatrists on staff, and it's a very nurturing place for them to be, and our being able to communicate with each other allows the transition to go more smoothly, which is more likely to allow our clients to be successful, and that's ultimately what we want. The other staff in our clinics, psychiatrists, psychologists, whether it's honestly on a formal level, it's oftentimes hard to catch a lot of time, but it's important and critical that we do either voicemail or actually catch a few minutes or email to really keep in touch with each other. And we can pop our heads into each other's offices to inform the psychiatrists if we're seeing a change in behavior that we think is important, whether we understand it or not. Is it a side effect of a medication or a behavioral change that indicates a psychiatric problem? Mm-hmm. So it's crucial that we stay in touch with each other.
Mm-hmm. And so someone could be referred to Jay's program, which is it's referred to the MRMI track of the day treatment program, and then that could become part of the assessment in the clinic and an ongoing conversation as to how a person's development is. Well, I thank you all. I want to give time to give a few telephone numbers so that people can get in touch with you if they are interested in these programs. Jay, if someone is interested in finding out more about your program, how do they reach you?
They would call Virginia Reiser, who's our program coordinator, at 946-6220. And we can send you literature on both our MIMR track or the larger geriatric program it's a part of.
Okay. And Leslie, for the outpatient programs?
949-7699, extension 377.
Okay. And I want to thank you, Dr. Munoz-Domecq, for giving your insights. And thank you all. I think it's interesting to hear how these developmental delays do affect mental health, but how we work together to help people reach their potential. So thank you very much for all that you do. I want people also to know that if you're interested in the community residential care aspect of WJCS, you may call Steve Yellen at 761-0600. I thank you for viewing, and good night.